I'm just glad that you didn't Google my last name because that may have not been good. All right, so I was tasked with the talk about KPIs, really, so you can all leave now if you want to. It's actually quite hard to make metrics and KPIs sexy and interesting, but it's incredibly important when you talk about data and you talk about being the director of a service or even being a coalface worker that wants to come to management and say, we need to introduce the Hamilton T1s. Show me the data. I want to see that the Stefan ventilator is rubbish. I can see that it's rubbish, but give me the data. I want to see what the incidences are of complications and stuff. So we need to be able to measure those kinds of things and provide data, and quality metrics or KPIs or targets is how we do it. So are you as good as you think you are? Well, we think we're pretty good because that's why we're retrievalists, because it attracts a certain kind of quality of we think we're good. But actually, are we as good as we think we are?
I am the greatest.
So Muhammad Ali, he is the greatest. And in fact, he said that even before he knew he was the greatest. But was he actually the greatest? Cassius Marcellus Clay Jr., born in 1942 in Kentucky. He graduated 341st out of a class of 390 from high school. Perhaps he wasn't the greatest student, but was he the greatest boxer? Well, he was an amateur boxer from the age of 12. He won 100 out of 105 amateur bouts and went on to win gold at the Rome Olympics in 1960. He turned professional at the age of 22 and he won 54 out of 61 of his professional bouts, 56 out of 61 of his professional bouts. And he then went on to win the world championship in the heavyweight division 3 times. So he was pretty good, but was he the greatest? How are we measuring that? Are we measuring that on his school performance, or are we measuring that on his number of bouts won? How are we measuring it? Who is measuring it? Who gets to say whether he's the greatest or not? He obviously said it a lot for himself. But what about in healthcare? How do we know if we are the greatest or we are good even in healthcare? There's lots of things in healthcare that has been said to be good. Thalidomide, heroin. Just want to point out to you that you can buy it for $4.85 an ounce, but less if you buy it in larger quantities. That was for Cophylexes. Okay, you can use old gold cigarettes for your sore throat, apparently. If you want to stay thin, I'm always looking for a way. Apparently, we should eat sanitised tapeworms. This was a soothing syrup that contained both opiates and alcohol. I can't actually see a problem with that, but perhaps I should. And I'm not really going to comment on Trump's greatest healthcare plan of the world in 2017. Time will tell whether that turns out to be a good plan or not. So there's lots of things around that state that they are good, but perhaps have been proven later to not be so good. So being less bad is actually not being good, okay? What are we aiming at? What do we mean by being good in healthcare? What do we want to be? Well, most of us want to be good physicians. We want to provide good healthcare services. But what does that actually mean? If you look at the Oxford Dictionary, which I quite like, being good is about living up to a particular high standard or being of good quality. So it's a description of the quality of the service or the kind of doctor or healthcare professional that you are. So if we think about quality then as the similar name for good in healthcare, what do we mean by quality? Sorry, this is a dinosaur slide. I look around and I see the Don't Forget the Bubbles team and I think, I know it's one that I didn't change, but anyway, just bear with me. It's got a bit of information that's useful. So clinical quality is generally what we measure, and most of you will be aware of the Institute of Medicine from the States describing quality as being safe, effective, patient-centred, efficient, timely and equitable. And that's pretty good. And if we can measure that kind of quality, that's probably a good thing to do in clinical quality. But we've heard quite a bit about the other side of quality. So what we think, I think that if you come into my emergency department and I can get you treated and sorted nice and quickly, I think that's quality care. But what about the patients and their family? Is that what they think is quality care? Because in actual fact, I think that if a patient patient comes in and is treated rudely or is hurried along in their process and doesn't get the time to ask the questions or the information that they need to know, that they might, although they've been sped through an emergency department and gotten treatment, they might get to the end of that journey and actually think that they had a bad experience because they didn't get their perceived quality. Remembering that perceived quality is about perceptions of quality, and it's a really complex and multifactorial thing that people perceive, and it's based not only on the quality you deliver, but it's based on their experiences at the moment, over time. They might have been there before, they might be coming back again. They might have spoken to Auntie Nell down the street who took little Johnny there 10 years ago and had a bad experience. So unfortunately, it is also based on rumour and hearsay. And it's a really important part of, are we really as good as we think we are? We've got to be good at giving care, but we've also got to make sure that the patients and families perceive us as giving quality care. So if we think about how we're going to measure quality, how do we measure how good we are? Well, we can measure clinical quality, in fact, by measuring measurable outcomes, otherwise known as KPIs, targets, quality metrics. So there's sort of a lot of names. Those names are used to sort of hide the fact that it's all about the same thing, but they are measurable outcomes. What about perceived quality? How do we measure perceived quality? That is a lot harder, and you're going to have to be looking at things like consumer feedback, and then you're going to have to be responsive to it, because it's not good enough just to have the button on the way out of the emergency department to say, how was your experience today? Rubbish, and out you go. That's not useful. You actually need to get the feedback that is going to inform you of what aspect of the quality did they perceive as being poor. We're going to concentrate a little bit about measurable outcomes, because in actual fact, when you go and look for perceived quality measurements, they're really hard to find. But there is quite a lot out there at the moment in terms of measurable outcomes. So what makes an outcome or a target a useful target? And I've put down a list of things that I think make them useful. They need to be standardised in definition. It's no good me saying that apples are great and I'm only looking at red apples if Paul's looking at only green apples. We need to actually be comparing the same thing. It needs to be reproducible over time and across different sites. It needs to be relevant, and I mean clinically relevant, not to the data people, not to the financial people, but actually to the patients in a group that we are practicing on. They need to be understandable. So, you know, measuring the change in serum rhubarb might be fine for someone who's a serum rhubarb expert, but it may mean absolutely nothing to the trainees, and more importantly, it may mean absolutely nothing to the people that hold the purse strings. So you want to be measuring stuff that actually means something and people can understand it. It needs to be able to be collected. There's a lot of measurable outcomes that we would like to do, but actually they're not, they're very difficult to measure, and so you spend a lot of your time chasing your circles, trying to get this data, and it's actually quite hard to do. And you need to regularly review them, because what was useful 10 years ago may in fact not be useful a little bit later. When you start looking at measurable outcomes, you need to be really careful of the unintended detrimental effects that you might actually put in place. And we're going to spend a little bit of time now and look at some of the doozies that are around, just for some cautionary tales about measurable outcomes and whether in fact we should be doing them at all. Okay, so for those of you that are emergency physicians, you may groan at the slide in front of you. So this is the National Emergency Access Targets, or NEAT, and this was a report, expert panel report by Baggerly and Co. To the Council of Australian Governments. It was written by this National Partnership Agreement on Improving Public Hospital Services. Lots of really long business type words there. And this report was in June of 2011. And it was a combined emergency and surgical reform, essentially. And it was put in place in 2012. And the aim was that by 2015, 90% of patients that presented to the Australian emergency departments would be admitted, discharged or transferred within 4 hours of getting there. And the reason they put this in place was that they looked at patients that were admitted to the hospitals, having been to the emergency department, got admitted, and they looked at hospital standardised mortality rate for these patients, and it was high. They actually, the longer you spent in an emergency department, the greater your length of stay, and the longer the delay, the higher your mortality rate was if you got admitted. So it was felt that by reducing the waiting time in emergency and giving more definitive redistribution of those patients, that we should be able to affect the national mortality, the hospital mortality rate. So the expert panel report, which I'm sure you've, if you're an emergency physician, you've all read in detail, probably not, but it's been my joy to actually read it. And it's really well written. And the reason I say it's really well written is it's got some really interesting cautionary comments in it. So it was designed to improve public patient access, that's fine. It recognised the risks that imposing those targets might have, so unintended adverse impacts or a negative effect on safety and quality of care, to the point that they actually went and said, we're concerned that by putting targets on moving patients quickly through emergency, that we're going to worsen things. And so they wanted to try and measure how we worsen things. And this was how they were going to monitor it. The interesting part is the second to last point, measures of the patient experiences with health services, which was in the paper, but I've never seen it measured. I couldn't find any data on it. It doesn't appear that it ever registered past the expert panel recognising that that's what we should be looking at. But in fact, nobody ever measured it. So they wanted to measure all of that, plus everything we already do, which is how quickly we saw patients and how long they waited and whether they came back in an unplanned way. When you look at the data for NEAT, though, it's really difficult to find all of those other measures. So it's quite easy to find data on how the mortality ratio went, etc., which I'll be talking about in a minute. But in fact, a lot of those other monitoring things, although recognised within the original expert panel, really haven't been looked at in detail going on. So you can have a really good idea, you can recognise that there are areas that you need to concentrate on, but sometimes it gets lost in translation. And so I guess that's cautionary tale number one. Don't let the detail get lost in translation. There's a couple of other quotes from the paper which I have very subtly highlighted for you in red, that the NEAT 4-hour rule should not, that the target should be not as an end in themselves. That's important. You shouldn't be just aiming at the target. You need to remember the broad goal of why you're introducing these targets. And my personal favourite, the meeting of the targets cannot be solely the responsibility of the emergency department. Right, let's move on. So, how neat was NEAT, all right? Remembering the aims, 90% by 2015, in and out of the emergency department within 4 hours, and we really were looking to see a reduction in the in-hospital mortality. This is a great slide. So the pale blue on the left-hand side of each of the graphs is pre, okay? And then the colours from there are how we went every other year by state. So I'm just going to point out that Northern Territory, they got worse. South Australia, that's where I'm from, we got better and then we got worse. But we didn't quite get back to baseline, which is encouraging. But this is your 90% here, this red line here. So no department anywhere in Australia ever reached the 90% by 2015. So we weren't all that neat. But did it have any other benefits? This is a great paper by Sullivan and Co. And they demonstrated that, in fact, the NEAT compliance did rise, as you saw in the previous graph. And in fact, it went from 25% to 45% compliance, that is compliance with getting patients out within 4 hours for admitted patients. So we actually improved 45%, really. But anyway, we did get a little bit better. For total patients, it was slightly better than that. But what happened was this. If you look at this fantastic graph here, this is emergency hospital standardised mortality rate ratio up here, all right? And so as we become more compliant with our NEAT, the hospital standardised mortality rate for admitted patients gets better until about 65% compliance. And then it goes up to worse than it was before we were not compliant. So in fact, the standard mortality ratio got worse the better we were at kicking patients out sooner. This is a target that has gone mad. The goal has been lost, okay? The outcome is not right. So the problem is we've also demonstrated, this rule has been in place in the UK for many years, and in fact none of the studies in the UK assessing the effectiveness of these 4-hour rules has demonstrated any long-term benefit in any aspect of quality. So even though a lot of hospitals can make the targets better, they can make that 4-hour target, in actual fact none of the measures of qualities actually improve. So why are so many hospital EDs and hospital management and the government still looking for us to achieve these neat targets. This is a classic example of us losing sight of the goal in order to chase down the target. Nobody's remembered that in fact the goal is to improve quality of care. We haven't done that. We should probably stop chasing a 4-hour target. But at least you're not dead. Okay, let's face it. Being dead is not good, and so in terms of quality improvement, I would rather not be dead. However, it's a really broad stroke measure of whether we're providing quality care. It doesn't really address any of the safe, effective, timely qualities that we've thought about in terms of clinical quality, and it certainly doesn't address any of the perceived quality stuff that we're talking about. My perspective is that if I'm not dead, that's good, but actually I would prefer that my quality of care was slightly better than that. The other thing that was interesting about the NEAT targets is that in order to get patients out of the emergency department quicker, what we did was we just admitted them to the short stay ward. And so we actually diluted the hospital admitted patient mortality, because actually not so sick patients got admitted and then they were counted in that mortality ratio. So the reduction was not actually a true reduction in the first place. What was wrong with NEAT? It was a single point of data. Okay? It was just a point of data. It never took into acuity. It never really looked at quality. And so it really wasn't a good quality measure. Another tale of caution, people may be familiar with the Mid-Staffordshire NHS Foundation Trust debacle. So this was a hospital system in England where they had absolutely appalling patient care, stories of true horror about how patients were not cared for, and there were a couple of inquiries into this, and the underlined statement suggests that it was in part the consequence of allowing a focus on reaching national access targets rather than concentrating on the quality of care. So perhaps we should just ignore measurable outcomes, because clearly they're perhaps leading us down a darkened path. Well, this was a great article by Saltz and Saltz, and it actually compared the changes in education in America. And they looked at this, they introduced a performance management thing called the VAM, where they looked at the individual teacher's impact on student education. And they sort of they looked at an expected test result for a student and then they tested them. And the difference between expected and actual test result apparently was teacher input. Had nothing to do with the kid's life or social circumstances. Apparently it was all about the teacher. And so the teachers were then graded based on their VAM scores, which has had a very negative effect in the education system there. The teachers themselves resisted this change. They loudly argued that this was going to do harm and that it wasn't any good, and so they really resisted. But it got done to them anyway. And the authors of this paper recommend that that physicians, they compare this to what's happening in healthcare, and they recommend that physicians would be unwise to resist the change, and that they would be much more encouraged to engage in the process but make it their own. So only by making it own can you actually guide the outcomes to be the outcomes that you want them to be. So resist at your peril. So how do we measure how good we are? Well, we need to engage in the process. We need to choose the right kind of metrics, and we need to not lose sight of the goal by aiming just for the target. Remember what the goal is. So let's have a quick look of the National Safety and Quality Health Service Standards. Again, long words. These were developed by the Australian Commission on Safety and Quality in Healthcare, and a huge amount of collaboration and consultation was put into it. Lots of stakeholders, lots of clinicians, lots of patients, lots of everybody. Great aims: protect the public. That sounds like a superhero statement, protect the public. And improve quality of health services. It was endorsed in 2011. It's going to be reviewed. It is being reviewed currently in 2017. In fact, there's a paper out at the moment which is looking at guidelines for applying these to services that deliver care to children. Those comments and stuff, consultation process will end on the 31st of August. If you're interested, you should get online and have a look, because you could make some comments about how it's going to be applied to our patient groups. So these are the quality standards. I'm sure that you are intimately familiar with them. Standard 2 is the one that's of interest to me, partnering with consumers. That's very important. We're going to get some information back on perceived quality with this one. How good are they? They seem to tick all the boxes for me. Clinical quality, they're looking at perceived quality. They are pretty good outcomes. My only concern, there's not a lot of information there about staff-based safety, because as we've heard multiple times during this conference, and I'm really pleased with it, is that we need to be careful about our colleagues and the people that we work with, and we need to be protecting our staff as well. So these are very patient-focused qualities, while as I think we probably need some focus on the staff as well. So this is my team when I was at Medstar, so I'm only recently have stepped down from that role. And we've talked a little bit about who we are. When I was the director of Medstar Kids, I started looking at KPIs or measurable outcomes in retrievals. And although retrievals have been around for a long time, in actual fact, there's no nationally agreed set of KPIs, internationally or nationally published anywhere. Nowhere. Retrieval's been going on for ages. Nowhere. Why is that? Because it's hard. So we had a question earlier about standardising retrieval services across the nation. Well, we can't even standardise KPIs across services. So getting the paediatric and neonatal services to actually agree to a definition of what is a neonate was what derailed the standard KPIs. We were working on that some 10 years ago, but we couldn't agree on the definition of neonate. The adults have done it slightly better. They are now, probably the last 12 to 18 months, they've had some statistics, but only 6. There's not a lot there. So I had a bit of a look around, came across an American group that have done the hard work for us. Let's not reinvent the wheel. Let's find some stuff that's already been done out there. So these guys, American Academy of Paediatrics and the Air Medical Physician Association, they had a couple of summits, or they like calling them summits, it's quite fun, and they came up with, independently, they came up with 12 and then 22 metrics. Paediatric, neonatal, and then adult and paediatrics. And then they combined them and ultimately came up with this collaborative, consensive, quality, blah, blah, blah. You can read it. 27 metrics, precisely defined. 15 of those are clinical, 9 are safety, both patient and staff safety, and 3 are pure logistical. How quick did you get there? How quick did you get them back? And they're pretty good. Those are the metrics. We have no time. I'm happy to share this information afterwards, anyone who's interested. But they're pretty good metrics. And then they put together this thing called the GAMET database, Ground and Air Medical Quality Transport Database. Free, web-based, you sign up, you put in your quality metrics as per their definitions, and then after that you can then receive a yearly report on how you're going in comparison to the other transport services around the world, and they are now starting to look at can they benchmark. So not only is it a repository for data, they're now looking and going, well, actually you probably need to be 75% compliant in this area. That makes you a good service. So it's a growing field and one that I would recommend. Talking about dealing with management, this was our journey with GAMET. So I started thinking about it in mid-2015, and we took 2 years to get it up and running. We are only just starting, they are only just starting to report it at Medstar. So I'm excited to see the outcome of this. That was what we did in terms of our database. We used the Air Maestro database, and we've introduced a GAMET tab, which collects the 13 data points that we need, only 4 of which you have to manually enter. Everything else gets automatically brought across from our other data pages. That's the kind of report you get, which is going to be interesting to see. So once we think we are good, what do we then do about it? Well, you need to talk about it. You need to communicate. You need to communicate upwards to your management team and your executive in order to help the bean counters give us the appropriate amount of money, etc. You need to communicate downward to your team and your users to let them know how you're doing in terms of things. You need to communicate laterally. You need to communicate across states and internationally. And we need to think about learning from excellence, which is a talk that Adrian Plunkett gave at SMAC in 2016, which is great, looking at learning from what we do well. How do we learn from what we do well, rather than just focusing on the negative? Remember to communicate regularly but meaningfully. Just filling your manager's inbox with data is not helpful. What's your goal? Why am I sharing this information? What do I want out of it? Am I just keeping you informed? Do I really need to keep you informed? So think about why you're providing the data. So being good in healthcare is hard to define, but it is certainly more than a sum of measurable outcomes. It includes perceived quality, and we need to think and think and be smarter about how we measure that. Consumer feedback is great, but often it's only the ones that have an issue that actually feed back to us. So how do we do that better? You need to seek meaningful measurable outcomes and KPIs. You need to use the data to identify the problem, and then you need to solve the problem to fix the data. Don't try and go about it the other way. And you need to communicate the good stuff widely. I have actually run out of time, but we could probably spend a minute or two getting any questions. Thank you.